It's so wonderful to see all your big, beautiful faces. I'm so glad you're here. It makes me happy, I have to say. So today we're going to talk about the frontal lobe and the motor areas in the frontal lobe, and sum up our series of lectures on the motor system. You're going to see some data regarding what happens when there is damage to the frontal lobe in terms of something like a stroke. Some of the things that are done to help individuals recover from stroke. I'll show you a little bit of that. I'll show you a little bit about what's amputation. What does that do to the cortex? So if you lose your limb in an accident, how does that affect the cortex? And we'll learn a little bit about basically the final stages of making a movement, which is we've gone from the parietal cortex now to the frontal lobe. We have the premotor cortex and the primary motor cortex. They're going to generate the motor commands that are going to produce that movement. And we'll discuss what they do. So here's a central sulcus. And what we're talking about today are things in front of the central sulcus, which is the primary motor cortex, which is immediately anterior to the central sulcus, and then this premotor cortex, which is in front of the primary motor cortex. So in general, the cortex is a complicated area, and we don't really fully understand how it works. So very much this material that I'm showing you is things that are changing year after year as our understanding progresses. Much of the work that I've been showing you has to do with in primates, how, particularly monkeys, how the activity in the cortex depends on stimuli that you see, movements that you're about to make. But that's beginning to shift. So now there is, because of the ability to control individual neurons in the rodent, much of the literature now is beginning to shift to mice and rats and how they control their movements, how they respond to stimuli. And the reason for that is because whereas in the cortex of a primate you can record from a neuron, but you don't know what kind of neuron that is. You don't know if it's an inner neuron, if it's a layer 5 neuron, or it's a, what kind of neuron it is, what part of that structure in the cortex it resides on. In rodents, you can, with some confidence, identify the neuron that you're recording from, manipulate that neuron through what's called optogenetics. And so the field is shifting toward the rodents, because in the rodent you can manipulate individual neurons and you can identify individual neurons. But much of what I've been telling you about is a neuron in some part of the brain, but we don't really know what kind of neuron it was. But there are many kinds of neurons at any given part of the brain. All right, so that limitation still holds, because the data I'm going to show you is much of it is about the primates. And so we talk about neurons in the motor cortex and premotor cortex, and we have some sense of what they do, but we still don't really know what kind of neurons they were and what part of the anatomy of the system they participated in. So with that caveat, so I just want to make sure you guys understand where we are in terms of how to attack the cortex. Because we can't identify those neurons in the primates yet, much of what I'm about to tell you is colored by that uncertainty. But that's going to change as you guys learn more about the nervous system if you go to graduate school, if you become somebody who studies the nervous system, you will be able to learn more about this because the field is moving rapidly now. All right, so here's what you need to know. I'm going to summarize it in one slide. In the posterior parietal cortex, we learned that the neurons care about the location of things with respect to where you're looking. So they care about where's your hand with respect to fixation, where's your goal with respect to fixation, what's the value of the goal, how important is it to me, how much reward am I going to get for making a movement toward that goal. Well, we're going to learn that in the premotor cortex, the representation is no longer with respect to fixation, but it's with respect to where is the goal with respect to the effector that are about to move there. So if you're moving your hand, it's a representation of where's the goal with respect to your hand. So now what matters is the effector, not the visual coordinates of the representation, but what part of your body you intend to move toward the place where you have reward. And in the primary motor cortex, that becomes in terms of muscles. What muscles are you going to activate in order to make the movement to get the reward? So we go from visual coordinates that represents the hand, the target, the value, to effector coordinates. I'm going to move my hand to this location, and finally muscle coordinates, the system that's going to move the details that I'm going to have to pursue to make that movement. All right, so a rough idea of our network. So we began with the posterior parietal cortex. We have a location of the target with respect to the fovea. We have proprioceptive information from our eye, from our head, from our arm that tell us where it is. So you get proprioceptive information in the somatosensory cortex, visual information from the visual cortex comes to the posterior parietal cortex. There you get what's called fixation-centered representation of where's your goal, where's your hand. When we get to the premotor cortex, we have this difference vector that says where's the goal with respect to the hand. Finally, when we get to the motor cortex, we get the motor commands, the details of the movement that are about to take place. All right. So let's begin with the premotor cortex, and I'll describe to you an experiment that tells us that fixation doesn't really matter. What matters is where's the goal, where's the stimulus with respect to the hand, not where the animal is looking. So in this experiment, we have a monkey that's sitting down, and its arm is located, let's say, to the right. And when the arm is located to the right, a stimulus is going to be brought forward toward its arm. And sometimes the stimulus is going to be to the right, sometimes to the left, sometimes to the far left. so what I want to show you is that the neuromotor cortex about the direction that you need to move the stimulus, so you get close to the stimulus. The effector, so in this case is a cursor on the screen. You want to move the cursor upward. I care about upward motion of that sort of a far away notion of an effector, which is a cursor on the screen. So let's show you what this neuron does. So here's movement direction of the y-axis. You can move it to the right, up, left, and that's shown by the angles here. So here's the movement of the cursor that's taking place. And so what you see is that it likes movement towards 0 degrees. It gives you a lot of activity around movement onset. And it doesn't like it so much when you move toward 90 degrees. It tells you even less when you move toward 180. So it likes it when you move the cursor to the right, less when it moves the cursor to the left. It has tuning with respect to movement direction, and that movement direction is to the right. Now, as the hand rotates, very different muscles now are going to move the cursor to the right. So indeed opposite muscles are going to do this. But yet, the preferred direction of the cell remains the same. It still likes to move the cursor to the right. So it's representing things in terms of things on this monitor. I'm going to move the cursor to the right, and I'm not going to represent that movement in terms of the muscles of my arm. In this experiment, you're going to see activity in a cell that's in the motor cortex, the primary motor cortex. And this cell does care about which muscles are active. And as a result, its directional tuning rotates as the arm rotates. So it prefers a movement to at 0 degrees. It gives you lots of activity when the cursor is moving to the right. But when the hand rotates, it shifts to about 90 degrees or so. So depending on the muscles that are being used, you're going to have that muscle active when you move to the right when the arm is in this configuration. But when the arm rotates, that muscle is going to be active when the arm moves in a different direction. So the idea is that the directional tuning of the cells in the primary motor cortex is closer to individual muscles, whereas in the premotor cortex, it's with respect to the task. The cursor I have to move to the right, and I like rightward movements of the cursor. A higher level representation. Do you have a question about that? All right. And so it's no surprise that when you get to the primary motor cortex, you begin to see force representation. So here, the amount of force that you're producing will produce higher amounts of activity in the motor cortex. Sit more closer to what the muscles are doing. So in this case, what we have is we have an animal that's sitting down, and the arm is in the exoskeleton, so you can induce forces on the elbow and on the shoulder. You see the exoskeleton. The arm is sitting on basically a little robotic thing that is grabbing the elbow and the shoulder, and so that in order for the animal to produce hold the arm steady, if there's a force on the elbow, then it needs to push against it. If there's a force on the shoulder, it needs to push against it so that it can hold the arm steady at a particular location. What they do in this experiment is that they ask the animal to produce torques. So for example, here's a neuron that's recording when the animal is producing a shoulder torque. Shoulder torque is on the x-axis, elbow torque is on the y-axis, and the magnitude of the torque is shown by the vector. So you see that the torque that's being produced is on the shoulder, it's about 0.1 Newton meters. So shoulder torque, that's, in this case, a flexion. Now, the colored graph show you the neuron activity. So this neuron is very active when the monkey is producing a large amount of shoulder torque, positive. It becomes less active when the monkey is not producing much torque, and then it becomes even less active when the torque falls. There's another neuron that likes torque in another direction. So here is a shoulder extension, elbow flexion. So a movement that involves shoulder extension, elbow flexion. So this kind of a torque. And in this case, the neuron fires a lot when the force is in that direction, less when it's in the opposite direction. So you see force coding. Why? Because it's a closer relationship to the muscles. And it would be a preference for some combination of muscles that will produce a particular force pattern. So that's the primary movement. Okay. And indeed, when a movement is taking place, the timing of activity tends to be earlier in the premotor cortex, a little bit later in the primary motor cortex. Then you see it in the muscles of the limb, and then finally the movement of the body. So here's a finger movement, and you see the timing of the activity begins in the premotor cortex, then the primary motor cortex, then the muscles, and then finally the finger. Question? All right. Now, the next topic I want to tell you about is called a somatotopic map of the body, a homunculus. Homunculus, Greek word means little man. And the idea is that in our brain, we have representations of our body, and parts of our body that are close to each other, my fingers are close to my thumb, they're close to my elbow, they are also going to be close to each other on my brain. So beyond the motor cortex, the regions that represent the elbow, that activation produces movements of the elbow, happen to be close to the regions that produce activation of the thumb. And the first indication for this came about during the exploratory surgeries that are done to alleviate brain problems, say you have epilepsy or you have a tumor. While the surgeon is interested in removing the tumor or finding out the basis of the epilepsy, they also may ask you that would you be interested in participating in a question that we're trying to understand. And so in this experiment that took place in the 50s, Penfield, one of the early neurosurgeons, stimulated the cortex in order to understand what part of the cortex did what. So he's stimulating the motor cortex and regions around it. And so here's the central sulcus, and he's folded the central sulcus looks like this, so right? So here's the somatosensory cortex, the motor cortex, and they go down together and then they join at the bottom of the central sulcus. That's what a sulci looks like. So there's cortical regions inside the central sulcus, some to the anterior side, some to the posterior side. So he's unfolded that because he wants to show you what stimulation to one side produces versus the other side. The basic idea is, and I want to show you this because these are notes that he takes as he's stimulating and the sensation that he observes. Now, the patient is awake. There's no pain involved in the stimulation because there's no pain on your brain. Okay. So you can stimulate the brain, and you will not, it doesn't give you a negative thing, is that there is no pain associated with it. And you can then report how you feel about that stimulation. So how did that make you feel? And some of that is shown here. And you can see some of the notes that you made. But the point that I want to make about this is that the basic idea is that things that are more closer to the medial part of the cortex tend to be proximal things, like shoulder and the elbow. Things that become more distal as you get more lateral on the cortex, they become the fingers. If you go even more distal, you become the mouth. So this is called a motor map, and it represents basically a map of the body on your motor cortex. And it is summarized via an experiment that goes like this. So in this experiment, what's done is that this is a monkey now. An electrode is inserted, and you stimulate, and you record what happens when you get stimulation. And so you notice there's some shoulder area. So here's the midline. Here's the middle of the cortex. This is the left hemisphere. And you see that up and toward the midline, you get the shoulder. As you get farther out, you get the digits and the fingers, and then down here you get a little bit of the mouth, the chin, the nose, and so forth. So the general trend for what's called a somatotopy, the trunk is more medial, the jaw is more lateral. However, movements of a given body part, say the digits, is evoked from multiple areas. So there's no strict division so that all the hand-related things are in one place and all the eye-related things are in another place. It's not the case. there's this mix in the two. But the basic idea is that you have a map that kind of looks like this. That basically in the midline of the cortex, way up here, you have the toes, the feet, the trunk, and then as you get further out, you get the neck, the nose, and the face. Now, one of the things you notice in these cartoons is that they're always on males. and I want to tell you that's a problem. Because, of course, not only half the population is females, but that there are things that are specific to females that are just not represented in these maps. So you don't have to, I don't have to tell you what's not represented. You can look to see there is no breast area on this map. Why is that important? Because I'm going to show you what amputation does to these maps. And so what is an example of an amputation? That is influenced primarily in the movement. Yes. And so there's almost no data on what that means with regard to changes in the cortex. All right. Perhaps you hadn't thought about amputation at that point, but that's in fact what that is. Okay. So the idea that there are maps in our cortex was established in the 50s and 60s. The new idea that came later, 20, 25 years later, was that these maps are not static. That although you may be born and have this map developed through mechanisms that have to do with development, once they're formed, it used to be thought, well, that's the map that you have. But I want to show you that damage to the nervous system causes changes in this map. But more interestingly, simple things like plasticity that's involved in learning causes changes in these maps. So sometimes that learning can cause problems which are a result of maladaptive mechanisms that produce problems like pain and so forth, which I'll show you briefly. So the first idea comes from the notion that if you were to damage a component of the motor system, it causes a change in these maps, and these changes take place rapidly. So I'm going to show you how that takes place. So in this experiment, what we have is a rat. And so first of all, you notice that the cortex of the rat doesn't have any sulcine, it's smooth. So here's the motor cortex of the rat, and this is the region that's going to be mapped here. So you insert an electrode in this region, you stimulate it. Every time you stimulate, you notice what part of the body of the animal moves. And notice that the forelimb moves when you stimulate here, the bristle moves when you stimulate here, the eyelids move when you stimulate here. So that's the map of these three areas in the cortex of the rat. Now what's done is that you cut a branch of the nerve that supplies the motor axons to the muscles attached to the whiskers. So you remove the nerve that goes from the spinal cord, you cut it, that goes from the spinal cord to the whiskers of the animal. So of course now, there's no way for stimulation to produce motion of the whiskers, right? But what's interesting is that a few hours after this is done, you notice that these maps have changed. So now the region in the cortex, the motor cortex, that used to produce movements of the bristle, now seems to produce movements of the forelimb and the eyelids. So that space seems to have been taken up. Okay, so how did that happen? Here's how. Normal scenario is that if there's a neuron in one region of the cortex, say the bristle region of the motor cortex, it of course sends its axons to the spinal cord, and then that goes out to the whiskers muscles, and that causes movement in the whiskers. So you've cut the nerve that goes from the spinal cord out to the muscle. So obviously now when I stimulate the bristle, I'm not going to get movements of the bristle. I see the motor cortex, down here is the spinal cord and the muscle. So this path has been cut. But under normal conditions, stimulation of this neuron spreads to the neighbor as well, but then is cut off by this inhibitory inner neuron. So under normal condition, there are excitatory connections to the neighboring region. So this activity would activate the forelimb, except that that activity is cut off by this inhibition. So this is why normally stimulating this area causes movements in the bristle, not in the forelimb. But what happens is that when there is damage to to the motor pathway. The cortex sends commands but doesn't get any sensory feedback. That causes plasticity. And what it does is that it reduces the weight of the synapse, this inhibitory synapse, that's going from this inner neuron to this forelimb motor neuron. That reduction in the inhibition makes it so that now when you stimulate the brissa, you get movement in the forelimb. It spreads. Okay, so that produces change in that motor. Yeah.
Does that give you more control over, say, the forelimb and the eyelids?
Yeah, no, because all that does is that it makes this area become an area that you have to learn not to stimulate. Otherwise, you're going to get movements in the forelimb. Okay. So, in the last 20 years, we've been involved in lots of wars. And those wars have produced a lot of people that have been amputated. And that amputation has led to really one of the things that's been a result of that is that it's been a result that it has produced a lot of changes in our understanding of the cortex and how it controls movements. It's because when an individual is amputated, what happens is that the sensory and the motor information is going to change. You no longer have the ability to send commands and receive input, receive feedback from the part of your body that's been amputated. So then the question is, do these maps change in these individuals? So first I want to show you they do change. Next I want to show you that sometimes that causes problems with people. It makes it so that they have pain, and it's called phantom pain. The kind of pain that you have in a place that you no longer have. So you have pain in a part of your body that doesn't exist anymore. How could that be? And then we can talk about what might be the basis of that, and we'll learn a little bit about some of the techniques that are used again to help these individuals. Okay, so amputation. In this case, what we have is that we have a person that who's been amputated on the right arm above the wrist. So, someplace like here. Now, look at what's remaining. Of course, this is gone. What's remaining are the muscles of the elbow and the shoulder. And so these muscles can be stimulated through the contralateral side. So you take a transcranial magnetic stimulator, you place it on the head, and you stimulate, and what you see is that you see EMG in the muscles that are left. And then you can move it around, and you can find the area, the size of the area on the cortex that produces this, not on the cortex, on the head. So this is this individual that they don't need any surgery for this. You just have them sit down, you put the stimulator on the head, and you stimulate, you find the area on the motor cortex that produces activity in the biceps, and you move it around until you map out that region. Now, once you do that, you do it again, but you do it on the other side. So now on this side, you do it and you find the region here. And that's shown in the biceps. So here's the biceps area on the right side, here's the biceps area on the left side. The left motor cortex is controlling the right arm. The right arm has been amputated. And what you notice is that the biceps area on the side that's contralateral to the amputated arm is larger than the side that's healthy. So the thought is that that amputation has caused plasticity in that person, and that plasticity has led to an enlargement of the area that was neighboring to the part that has been lost. Does that make sense?
Yeah. So I don't know if I didn't. You have worse control, better control over muscle?
Right. Unknown. I will show you that with learning of certain skills, the areas do get bigger. So if you're a violinist, it is likely that your representation of the side that's used for moving the bow is probably bigger than an average person, whereas the finger area on the contralateral side is bigger than an average person. So basically becoming expert at something is using topography, it's using geography essentially. It takes neurons to do that. And indeed it seems to be the case. Although the evidence is, from fMRI, we of course don't know. We don't have monkeys that have any skills that are different from each other. Okay. But you know, it's a conjecture that I'm making. It's based on indirect evidence that comes from these neuroimaging studies. Okay. So, but also we have absolutely no idea whether they're better with their biceps on one side. It's just that the area is bigger. Okay. So, what does that do? Is it good? Is it bad? So it turns out that there's some indications that individuals that have a large discrepancy between the size of these maps on one side than the other after they've had this amputation, they're more likely to have what's called phantom pain. So phantom pain is this condition where an individual can have pain, and it can be debilitating in a body part that no longer exists. So you have no pain receptors that are coming from your hand because you don't have a hand. But you can have pain in that body part, it's called phantom pain. And what the slide is showing you is that there are 3 patients on the top, there are 3 patients on the bottom, different people. And the patients on the top, they're non-phantom limb pain. So these are people that have had an amputation, but they don't suffer from pain. The ones on the bottom are the ones who do suffer from pain. And there's some indication that this occurrence of this pain is due to a asymmetry in these nerves. So one side is much bigger than the other. And the thought is that maybe this is one of the things that is resulting in this. And the question might deal with why. Why would there be pain associated with this loss of sensory information? And we don't know the answer, but I want to show you some conjectures to that. So in this plot, what I have put together is how does learning take place. So you have some motor commands that you send to your body. That produces some sensory consequences, and you see it and you feel it. So you move your hand, and you see your hand, and you feel your hand. Where if you didn't have a hand, you could still send the commands down, but there would be no sensory consequences. Your arm wouldn't move, and you wouldn't see it. You wouldn't see any movements. So you have this gigantic discrepancy between what you expected to happen, because that's what you've done all your life, and what you actually get back. And the thought is that, well, maybe this discrepancy, because it's so big, is a condition that results in pain and makes this debilitating condition for these people. And so an ingenious idea that came about is that, well, maybe one way to help these people was through something incredibly simple, which is basically a mirror. And you see that. So suppose I've lost my left arm, and now you place me in a mirror, and what you do is that you have me make movements with my right arm, and you make me look at this mirror. So if I don't have a left arm, and you're asking me now to make bilateral movements, if I look at my left arm, there's nothing there, and I can't see it move. But if I'm looking at a mirror and I'm moving both arms together, it looks like I am moving my left arm. Huh? And it's actually a rather striking illusion. To do it on yourself, you get yourself a mirror and have yourself make movements, and it really looks striking. Like it really looks like you're moving your arm, and you're looking at your arm, which of course you're not. You're looking at your hips a lot. So some of the rehabilitation that's done in these individuals, some of the things that comes about with regard to the improvements that they see has to do with this simple mirror therapy. So there seems to be some daily use that seems to reduce the perception of pain. Maybe the pain is coming because of the discrepancy between what they expect to see and what they actually see, what they expect to feel and what they actually feel. And through simple things like placement of a mirror, you can potentially reduce it. And so there's some clinical trials that are going on to verify whether these claims make sense.
So theoretically, if you had a prosthetic that was like super realistic, would that have a similar effect to this?
Yeah, it's interesting. That would potentially be similar. Yeah. Yeah.
So I know you talked about like the weight of the inhibitory pathway earlier, and like how like the reduction of that weight is kind of what leads to stuff like this. Has any research been done about like maintaining the weight of that pathway in order to prevent this from happening in the first place?
So let me tell you about the problems with doing this kind of research. If we're talking about humans, right? So we can't really measure nerve physiology. They can tell us that they have pain, and you can try to do something about but you don't know the basis of it. In a monkey, it's hard because the monkey can't tell you it has pain, but you can measure neurophysiologically. But also ethically, it's not clear that amputating in monkeys is necessarily a good thing to do. Right? So unless there was some injury that took place and you had to do it anyway to save the animal's life, it's just not something that's done. You can then say, okay, what do we do it in rodents? You know, maybe we have less ethical concerns with letting the dog off from the mouse. And, you know, one can debate that. Why? You know, it's a cost-benefit analysis. What's the knowledge that you're going to gain? Who's it going to benefit? And then one has to consider the pain issue and the deficit that you're causing the animal. So, but in a mouse, you know, I don't know. How are you going to determine this concept of so it's really, really hard to get at these questions from the human level. Yes?
Stuff like this also like paralysis or still can.
So, yeah. So I have not heard of this phantom limb pain and paralysis. I don't know. So like spinal cord injury, for example. I don't know of any scenarios like this. But remember what I told you about mastectomies. So mastectomy is a form of amputation. And is there phantom limb pain in that? Does anybody study that? Not that I do. So here's an area to consider. That's a much, much larger area than it is in amputation because of accidents or amputation. Okay, any other questions? Yeah.
If you've been amputated and like in this experiment, you're told to try and move like the place that you've been amputated, where is that coming from? Like a prosthetic that's been remounted?
So people have done experiments on this using fMRI again. And they have done it using scenarios where before the amputation, they ask the individual, say the hand has been amputated. Now, what remains is that the muscles that connect to the hand muscles, they're up here. So you can actually put electrodes here and you can see they're trying to move those muscles. So you can verify that despite the fact that they don't have a hand, they are activating muscles that would have moved with motion. And then what they did, and you can see some activity on the cortex associated with it. Then what they did is that they have scenarios where you can get a real hand from a recently deceased individual that you graft onto the person's hand, try to connect the nerves, and you have them try to learn to control this essentially hand of a different individual. And when they can do it, you can see how that map changes on the cortex. I don't know any such result in regard to prosthetics that are associated with it. But it's coming. I mean, the newest prosthetics, what they're doing is that they're putting in EMG. That is, say I've lost my hand, I'm going to learn to control my hand by acting on the muscles of my chest. So I'm going to activate these muscles. Those are going to activate the actuators on the prosthetic hand. Kind of like, what I was showing you with the shoulder movements and movements of the hand. Does that answer your question? Any other questions? Okay. All right. Our final topic, stroke, and how it affects the cortex and how that is then changes with rehabilitation. So, to study stroke in animal models, you have to give them a stroke. And this is now, this is something that used to be done much more easily, but it's becoming more difficult. And so in primates, it's becoming exceedingly difficult to study this question. In rodents, it's still quite possible. So let me show you one of the last studies that I know of that looked at stroke in primates. So what's done is that you occlude a vein that is supplying blood to a particular region of the cortex, or that you destroy the cells that are there. And basically, in this case, what's done is that here's a map of the motor cortex of the monkey. So here it is, the left and the right. The left and the right hemisphere. In the front, you have the motor cortex. Back here, you have the somatosensory cortex. And this region here, is on the dashed area, is mapped here. So you see that there's some places, this red is the stimulation, the motion of the digits. green is the wrist and the forearm, and the shoulder would be blue up here. So you see that there's a roughly a map. And now, of course, when this area is damaged and these neurons are gone, 3 months later, you go and you look at the brain again. So it's the same animal before and after the damage to the cortex. And you notice that, of course, this part is gone. It's not there anymore. It's black. But what's changed is that you see that there's a lot of, there used to be some red up here, and it's much less. So it's become more green. So you damage the finger area, the digits of the hand of this animal. Of course, the animal becomes less likely to want to use its digits because it's weak, and the hand becomes in a flexed posture. But that also affects the neighboring area. It seems like you used to have some digit area close by that you didn't damage, but that got taken over by the shoulder. So perhaps this is a bad thing, because what has happened is that there's not just loss to the area that was damaged, but maybe that caused the animal to become reluctant to use that body part. And so then neighboring areas grew because of lack of use. So here's the idea, that when you get a stroke, you have weakness. That makes it really hard to use that body part. And if you have any remaining representation of that body part in the cortex, the lack of use makes it so that even those go away. Okay? All right. Yeah.
Would it be like similar situation to like a person in a coma with lack of use make like those parts go away as well?
So we sort of saw evidence of this when we were looking at muscle fibers. Remember we said that in individuals that super athletes versus spinal cord injury, you have this very big difference between the composition of the quadriceps muscle. So lack of use is a factor in how the cortex is going to be organized. And so when there's stroke, there's going to be weakness, and that weakness is going to make it much harder to use that body part. Perhaps that makes it so that things become even worse because of lack of use. So one way to get around that is to do rehabilitative therapy. So what one sees, so how do you do rehabilitation in a monkey? What you do is that if the hand was affected, now you give it monkey exercises, so it has to use its hand. It has to use the hand to pick up a small piece of food, and through use, you encourage it to keep using it. In this experiment, you see that in the monkey that had that use-dependent therapy, pseudo-rehabilitation, this region that was infarcted, this region that was infarct means that there was a stroke there, of course it's lost, but the neighboring regions didn't lose the red. So even this region that used to be blue became more red. So it seems like rehabilitation therapy resulted in not just recovery in the sense that the hand was used more, but that prevented and encouraged presentation of these areas that wouldn't be lost if there was lack of use. So that led to therapies in humans. And let me show you what that looks like. So one of the therapies that led to these studies is called constrained motion rehabilitation. So it's kind of cruel, but this is what is done to help the patient recover after stroke. Suppose that I have my right arm that was affected because I had a left cortex stroke. So now my arm is like this. I don't want to use it. I'm going to become a person that's going to rely on my left hand to do things. And that's a bad thing, because if I do that, if I just stop using my arm, I become even worse. So what's done is that in this study, the patients come in and they tie their left arm to them like this. So they have to go through 8 hours a day of using their effective arm, the one that is weak, the one that has been affected by stroke. And that seems to have some benefits. Not in everybody. It's better than nothing, basically. It's better than scenarios where you simply leave them to themselves. And you see that there's some improvement. Here's some measure of performance before the therapy began, and then they begin the therapy, and then basically they keep it up for 12 days, and then they check the patients 4 weeks later, 6 months later, and you can see that there's some effect that lasts beyond the therapy itself. These are small numbers, like I don't know, 2, 4, 5, 6, 7, maybe 10 patients here, so these are not big numbers here. It's unclear if this is really a very effective way to deal with stroke, because lots of people get better anyway. So we don't know if they would have gotten better if you hadn't given them this therapy. Right? right? So that's how you do a control study. You have to say, some people are going to get this therapy, some people are not going to get this therapy, and then we're going to compare them. That's how you do a randomized controlled trial. But there's some indication that lack of use exacerbates the effects of this damage to the cortex. Forcing individuals to use it as a form of therapy prevents that loss and may be beneficial in the long term. Okay. All right. Finally, I want to show you what's learning about. So many of you guys participate in sports. You've learned skills. You know how to ski. You know how to play the piano. These are motor skills that you've acquired. And I want to show you that as you learn these skills, you probably are changing your cortex. And the maps that are associated with the control of that body part are changing, probably becoming bigger for the region that you're using to perform the skill that you're learning. So I'll show you this in this study about the motor maps. So a very simple skill that you can teach a monkey is that you can teach it to pick up a piece of food from a large well, like this, or from a small one. But of course, you don't have to do it with your monkey, right? You can do it with your cat. So these are good things to try to cognitively challenge the animals that you love. Give them something fun to do. At the beginning, it's going to be hard, but then they're going to learn how to do it. So large well training is really easy. If you do large well training, the animals don't have to learn anything. They know how to pick up a small piece of food from a large well. They do it like this. Small well training is hard because what they have to do is to put their fingers in together to pick up that piece of food. That's a hard thing for them to do. And if you practice, you can learn to do that as well. Okay, so what happens to the brain? So here's small well training, here's large well. So here's an animal that with large well training, of course there's nothing to learn. So the map of the motor cortex before and after is largely the same. But here's small well training. The map before training and the map after training, you notice these yellow areas have gotten big. You have more yellow areas in the post-training than you have prior training. Now, you notice that, of course, the space in the cortex is limited, right? So you only have a certain number of neurons. And so you can ask the question, when I'm doing this training here, am I losing the ability to do something else? And, that's a great question. We don't know. We don't know the answer. All right. Any questions about this? All right. Let's summarize. Posterior parietal cortex. We learned that you need to represent the world with respect to fixation and assign value to the stimuli that tell us what's the goal, how much of a reward I'm going to get for it, where is my hand and with respect to fixation, where's the target with respect to fixation. In the premotor cortex, we have a representation of the goal with respect to the effector. I care about moving the cursor upward, not about the muscles that are going to move the cursor upward. In the motor cortex, I care about the muscles. We learned about the maps that exist in the motor cortex, that plasticity can change those maps, amputation can change those maps. You can get phantom pain because of loss of a body part, and we learned that through use, those maps can change and become larger or smaller depending on the experience that we have in our body. Any questions? All right. Have a good weekend and good luck on your test.
What energy?